we're going to welcome three of our oncologists, and we're going to speak to the topic of updates in medical oncology in kidney cancer now and in the future. And I'd like to welcome Dr. Laurie Wood, Dr. Neil Riome, and Dr. Jeff Graham. I'll just give a quick intro for each one of you. I hope you don't mind. We'd like our patients to know who you are. And Dr. Laurie Wood is a medical oncologist. She's a professor in the Department of Medicine at Dalhousie University with a cross appointment in the Department of Urology. And Dr. Wood's clinical research interests are I always struggle with this word, genitourinary cancer malignancies, especially renal cell cancer and testicular cancer. And she participates in a number of phase 2 and phase 3 clinical trials, as well as national research initiatives. And Dr. Jeff Graham is joining us from out there in Manitoba. I forgot to mention Dr. Laurie Wood is in Halifax, so we're kind of covering the country. And Dr. Graham is a medical oncologist at Cancer Care Manitoba. He's an associate professor in the Department of Internal Medicine at the University of Manitoba and an affiliate scientist at the Cancer Care Manitoba Research Institute. And last but not least, we are joined by Dr. Neil Riome, right in the middle in Ottawa. And Dr. Riome is a staff medical oncology at the Ottawa Hospital Cancer Centre and an associate professor at the University of Ottawa. He was previously director of the University of Ottawa's postgraduate medical oncology residency training and is now the head division of oncology. Thanks so much. I'll let you take it away.
Thank you to Kidney Cancer Canada and Christine and Mona. Thank you all for asking us to be at this session. Why we do what we do is to help patients, and kidney cancer is an important disease for the three of us, and we are very honored to be asked to speak at your patient and caregiver information session and annual symposium. So again, thank you. With three of us, we all could talk for hours if you asked us to on kidney cancer, but we won't. And what we've tried to do as the three of us is kind of come up with some questions and topics that you might have as patients and families. And we've made about 15 to 20 slides, and we may or may not go through them all. We're happy to have questions come in and let us know. We can chat along the way, or we can save them all at the end, but I have a feeling it'll probably work better if we bring them up as we go. And the three of us are going to try to get our slides right and speak at on the right slide. So we'll see how it goes. So if we could have our first slide, please, Cassian. And our topic is really where we are now, and again, where we might be in the future with kidney cancer. Next slide. So these are our objectives, is to kind of talk about the treatment options for advanced kidney cancer that we have, discuss some of the side effects that may be related to them and management, and what may be coming up down the road. Next slide. So I'll pass it over to Neil, who is my colleague in Edmonton. I was about to say Neil, Ottawa. And Neil just kind of talk to you about a case that we unfortunately see all too often in our clinics.
Thanks, Laurie. Yeah, so it's glad to be here, and honored to be with my two panelists who are quite distinguished and much better looking than I am. So anyhow, our first case is a 54-year-old woman who presented with blood in her urine, which is a common way many patients present, but not all patients. So she would have been investigated, and workup showed that she had a left kidney mass measuring 8 centimeters. And I think we saw one about that size in Dr. Kapoor's presentation just prior to ours. And usually we do staging to see, is this the only site of disease or not? And that would usually involve something like a CAT scan or CT scan. And unfortunately, she was found to have lung lesions in both lungs that look like metastases. And so how do we know they're metastases? Usually how they appear on the scan, more peripheral, very rounded, as opposed to something like a lung cancer that would be a little more central usually, and very, spider and cobweb-like. So it usually has a characteristic looking, and we would probably move on from that point and do some workup and get a diagnosis, right? This is a radiologic picture, and that's important to us these days, because what Dr. Kapoor talked about what we see under the microscope is very important. So tissue is the issue for us medical oncologists. Laurie, and Jeff, did you want to add anything in about this case?
No, I think that was well done. I think the next slide goes into some further investigation. So yeah, thank you very much for the invitation. I'm really excited to be here with my two other panelists. So yeah, the question that comes up next is really what is the role of a biopsy? And I think in oncology, ideally obtaining tissue is really one of the most important things. I think particularly in this case where the presentation appears to be de novo, so they haven't had an nephrectomy, for instance, and a biopsy would be important. The question that often comes up is what do we biopsy? I think at least in Manitoba, if we can, it's nice to biopsy one of the sites of metastases, so one of the lung lesions if possible. But if they're too small or not amenable, then a biopsy of the kidney mass is also valuable. The question also is what type of pathology is the kidney cancer? And very broadly speaking, there's a distinction between clear cell, non-clear cell. By far the most common is clear cell. It makes up about 85% of the cases we see. And as we may talk about a little bit later, there perhaps are some treatment considerations in the metastatic setting, depending upon if it's clear cell or non-clear cell. Another thing that comes up sometimes is if you have a renal mass that's sort of near the bottom of the kidney or near the ureter, the question of whether this is a renal cell carcinoma or perhaps an upper tract bladder cancer is also something to think about. So next stage. So unfortunately for this case, it does look like this is an advanced stage given the presence of distant disease outside of the region of the kidney. And I think in previous sessions, there might have been some presentations on how to treat local or stage 1, 2, and 3 cancers. And I think the focus of this presentation will be mostly on stage 4 disease, which is where the cancer has spread beyond the kidney itself. Thirdly, prognostic factors. And I think in Canada, I think we're excited to have Dr. Hang, who works in Calgary, who developed one of the I think most widely used prognostic models in metastatic or advanced kidney cancer, the IMDC model, also the Hang criteria. And what that is, without getting into too many of the details, basically is a combination of various factors. So 4 of those features are blood tests actually, which we see on just routine blood work. And 2 of them are more patient-related factors. So whether the cancer developed sort of without a primary tumor that was diagnosed previously, and the performance status of the patient. So we use a combination of those factors to sort of group patients into 3 categories. And those 3 categories help actually determine, in some ways, what treatments we would offer, and also what we think the ultimate prognosis will be.
Maybe one thing I'll add is with regards to the non-clear cell, that's made up of a whole bunch of different types of cancer. And having done a lot of events for Kidney Cancer Canada, I know some of you that have non-clear cell cancers, papillary type 1 or 2, or adult Wilms tumors, or collecting that. We know many of you are very, very educated on your disease. And so we'll touch on some of the more common non-clear cell perhaps, but I do apologize. We don't have, unfortunately, the long enough to talk about the really rare ones like adult Wilms tumors and lymphomas and things like that. So we apologize ahead of time if you're in the audience in that with that diagnosis. Next slide, please.
Okay, I guess it's back to me. So at the time of diagnosis, I guess, kidney cancer was one of the few cancers that even if it's metastatic, like it isn't, we're presuming in this patient, that we still take the primary out. That's based on historical data. There was some studies done around the year 2000 that showed in the cytokine era. So we'll talk a little bit about systemic therapies in a minute, but in that era, the success of our systemic therapies wasn't as great. So nephrectomy was done at that time and has shown that it did provide a survival advantage in the patients that were able to undergo it. And so that was generally a 3 to 6 month survival advantage. Now, as time's gone by, treatments have changed. We're much more successful with our systemic therapies with the new targeted therapies and immunotherapy, and that's been now reassessed as to whether doing upfront nephrectomy is the right thing to do. So there's been a couple trials repeated in the targeted therapy era, one of which Dr. Laurie Wood, who's with us, was the Canadian lead on a study of doing it immediately versus deferred. Unfortunately, that study, it was hard to accrue to, and so it was ended a bit early, but did show to us that there was no detriment to delaying the nephrectomy in the short term, but in the long term, there was no, we're unsure as to whether there's a survival benefit that wasn't powered. There is some hint that there is still some ongoing benefit, but it's a very selected population. There's a larger study that was also done, the Carmina study, that's unfortunately shown that there's no survival benefit in their study, which was done. So it's really with targeted therapies, it's unclear whether nephrectomy adds anything, but there is still a subpopulation. So we have a Canadian consensus guideline after those were put out that said it's still up for discussion in very selected patients up front. But for the majority of patients, you'll see in a lot of the studies of systemic therapy now that were done up to now that many patients had nephrectomy, but as we're moving forward with lots of options now that are very effective, that number may start dropping off. So currently, at least at my center, and maybe Laurie and Jeff can say that upfront nephrectomy in our center is actually probably the minority of patients now, that most patients go straight on to systemic therapy.
I agree. Yeah, I would say that it's quite similar to our approach here in Winnipeg. You know, and there's I think cases where that may be considered in a multidisciplinary round setting, but by far the most common situation would be to go on to systemic therapy, which we'll talk about shortly.
Yeah, maybe I'll just comment by looking at one of our questions. One of the questions from Mona is, if surgery is delayed for some patients, at what point is surgery considered? And that's a great question. As Jeff alluded to, you know, these complex cases, we really do like to discuss at what we call a multidisciplinary rounds, where there's radiology, pathology, medical oncology, surgery all together. And who we usually do these days with cytoreductive nephrectomy is people that have had a great response to therapy and the bulk of their disease is still in their kidney, or very occasionally now, well, not very occasionally, sometimes now with treatment, you'll see where some sites are all controlled, but one site is still growing, for example, including the kidney. So in that setting of what the term oligoprogression, or progression just one site, if it happens to be the kidney, that may be another time that we consider it afterwards. But these are individual cases. Nobody follows a recipe. And so we consider each case individually, and we talk about it amongst all of us at our center. Neil.
Exactly. Yeah. At our center, generally, we get someone on systemic therapy, assess whether they're responding or not. You'd have to be a responder to probably move on to be considered for a cytoreductive nephrectomy. And generally, that reassessment period is at least 3 to 6 months down the road. And it's trickier when someone's on a therapy that such as a VEGF inhibitor, because you have to stop their systemic therapy to do the cytoreductomy and then wait. I'm not sure how long they wait in other cities, but you know, it's 4 weeks generally to get back on your therapy. So it has to be someone who can afford to be off therapy, in particular if they're on VEGF therapy for 4 weeks. So yeah, it's a hot topic, and we're looking forward to see. Now there is for people who, for one reason or another, can't undergo cytoreductive nephrectomy but are interested in local therapy. There is a Canadian-led study, CytoShrink, that's looking at radiation to the kidney to see if that improves outcomes on immunotherapy as well as controlling the primary tumor. So there's a little homegrown study going on that's a little different than the traditional cytoreductive nephrectomy. Now, the second topic listed there is metastacectomy. So, you know, someone who's had recurrent metastatic disease and is saying, well, why don't we just cut it all out? And that has been done. There is no randomized large study out there. And again, this is a multidisciplinary situation that people are put through to say, you know, how many sites of disease does someone have? How many organs are involved? Is it oligometastatic disease, which usually refers to less than 5 lesions? Are they on systemic therapy? Are they under control with the systemic therapy and no new lesions popping up while they're on that. And so that is something that is considered in very selected population, but there is no randomized study to give us great numbers on outcomes. There are some observational studies that have been lumped together to see in the highly selected patients that do go through it. There has been signs that there is benefit to those patients, but as a general rule of thumb, upfront mastectomy is probably very uncommon. But down the road, if someone's doing very well, has limited volume of disease, that could be considered in select. But again, it's a multidisciplinary discussion. I'll see if Laurie and Jeff have anything to add to that.
That's great.
No, I totally agree.
Oh, sorry,
yeah, that's
Jeff.
fantastic.
Next slide, Cassian. Okay, so what we're going to talk about now in general terms is what the big categories of treatment are, and then we'll try to get into smaller break it down, but we're going to start with the big ones. We're going to start with Jeff. Sure.
Thanks, Laurie. So yeah, so what is VEGF or VEGF target therapy? So I think one of the defining features of kidney cancer, renal cell carcinoma, is this dependency on angiogenesis, which is really a fancy term for dependency on blood vessels or vascular supply. And this was an early finding in research in this space, and it led to the development of drugs which basically tried to disrupt the tumor's ability to create new blood vessels. And these are really how a lot of these early targeted drugs work. So sunitinib, pazopanib, axitinib all have activity against this VEGF pathway. And the idea being, if we can disrupt the ability of the tumor to create and maintain blood vessels, it may lead to responses and hopefully improve outcomes. And trials have demonstrated that. So for a number of years, these were our standard first line options in advanced kidney cancer. And as we'll see shortly, they still play a role, but now are being combined with another class of medications, which I think Dr. Riom will touch on.
Okay, so yeah, Sutent and pazopanib and axitinib revolutionized the treatment of kidney cancer. It was like going from driving I'm dating myself, a Ford Escort to driving a fancy Lexus. It was great. We had something to do because we had been treating with immunotherapy. So I've been given immunotherapy as my topic. Well, immunotherapy back when I started was even less than a Ford Escort. And we did it. It wasn't very nice. It was the cytokine era, had very low response rates, lots of toxicity. But much like an old tie, never throw it out, it'll come back around in fashion. And now it's the hot topic. It is not just in renal cell carcinoma, across every cancer. This is a way of treating cancer that is revolutionizing. It's a new era for treatment of cancer. Essentially, it's not a therapy directed directly against the cancer, but it's using your own immune system, which is always supposed to be monitoring for cancer, and boosting it to do its job, right? And so what it is and it's, you can look it up. This won the Nobel Prize in medicine. Dr. Allison, he gives a great talk if you're ever able to see one. He and another investigator from Japan identified that essentially the brakes have been put on your immune system. So these are, you see the names on nivolumab, ipilimumab, and pembrolizumab, ends with AB. They're using antibodies to try to take the brakes off your immune system because the cancer has, one way or another, put the brakes on your immune system. And so Dr. Allison had found the friend end of the pathway. You might hear something about CTLA4 as a switch on immune cells that's being activated, and he's designed an antibody that will go block that so that the immune system can proliferate and be there for when the cancer's active. And so essentially what he's doing is taking that Ford Escort and moving it to the top of a hill to give it all the momentum it can have. And then the drugs like nivolumab and pembrolizumab block the off switch. Every immune cell has an on and an off switch for when it's acting on, say, attacking a cancer cell. And the cancer cells are able to hit the off switch to turn the immune cells off and hide. So this blocks that off switch, these secondary antibodies. And by using one or both, we've been able to reactivate the immune system and let the immune system attack the cancer. And it's very successful. It works in every type of tumor that it's been tested in varying degrees, but it's most effective in renal cell and melanoma. So it's the hot topic du jour, and we're still learning how best to use it. And we'll talk a little bit about that.
Okay, Jeff.
That was great. That was great. Yeah, sort of like the Tesla of new cancer drugs in some ways. So yeah, so the third point here is what other pathways can we target in this cancer? 2 drugs listed here: cabozantinib, lenvatinib. So the way I think about these, these drugs tend to also target that angiogenesis or blood supply pathway. In addition to targeting that pathway, these drugs hit some other molecular targets that appear to be important in kidney cancer. Cabozantinib inhibits, for instance, something called AXL and MET, which we think also help drive kidney cancer growth. Lenvatinib targets a pathway called FEG or FEGFR, so a fibroblast pathway, which also appears to be important in kidney cancer. And we'll see that perhaps some of these drugs can actually overcome some of the resistance that kidney cancer cells can develop when treated with drugs like sunitinib, pazopanib, and axitinib. And Dr. Ruma mentioned the Nobel Prize, and actually recently, the Nobel Prize was awarded to a team led by Dr. Kalin, who is a researcher who really helped develop, research in this space in angiogenesis and, how angiogenesis is important in tumor growth. And I think near the end, we'll talk about another pathway that is being looked at as another treatment option in kidney cancer. So yeah, there's lots of really exciting research, and it's translating into therapeutic advancements, which is excellent to see.
Great, thank you. So I kind of sometimes for patients, I'll actually go through, as Neil mentioned, 1980 to 2005. We had interferon and interleukin-2, which were called cytokines, which really were certainly not what we wanted. And then 2005 to 2016, 17, we had the VEGF targeted therapies. There was potentially another class, we didn't use it very often. And then really since 2016, 17, every year there's something new. And so it's really quite exciting because before this, it was really 2 eras, and now we have things happening all the time, which is exciting. So next slide, please. So what we do now is we said, well, if we've got these single agents at work, we know when we use chemotherapy for cancers, and there was one of the questions that came up that I'm not sure if the whole audience can see all the questions, but one of the questions came up, why don't we use chemotherapy? So chemotherapy just does not work in kidney cancer. But one of the rationales of chemotherapy is, well, let's combine different chemotherapy drugs for other cancers that work differently and have different side effects, so that we can maximize use and maximize cell kill. And traditionally, that hasn't been an option in kidney cancer until we've gotten these new agents. So the combinations now are combinations of immunotherapy and immunotherapy. And we apologize for the horrible names for these drugs. We find them tongue twisters as well. So it's not just you, we promise. And that's why we'll often just go with the first or second syllable of them. The second is immunotherapy plus the VEGF targeted therapies. So 2 different mechanisms of action. And then third is the immunotherapy plus these other targeted therapies that Jeff just mentioned. So there are specific drugs and names that fit under each of these, but really this is the key take-home message: combination therapy and what you're combining. So we'll move to the next slide, please. And now we're going to have Neil kind of talk about how we choose which one of these combinations to use.
Well, that's the $1 million question these days. And there's, you can go on Twitter and watch a debate on this one, at least one a week I see on that. Yeah, so they're all, all the options that have been listed there are effective. I guess really these days, what it comes down to is we look at the patients, we look at stratify metastatic patients as by prognostic factors, as Jeff mentioned before, using that IMDC criteria. And based on the data, that which of those combos works best for that group of patients, we then say, okay, here's the menu of the ones we have to choose from. Many of the patients have the options of both the dual immunotherapy versus the hybrid. So I'm getting back to my car analogy there, system. And so we have to look at, how did the patient present and what is their biggest issue at that time? Someone presented with an incidental metastatic, no symptoms, doing well and fit where they're eligible to get both. We might say, well, listen, immunotherapy works really well, but sometimes takes a little while to kick in for some patients. This person's totally asymptomatic. We might suggest that for them. Other patients have what we call disease that's, going to cause problems in your future or is already causing problems. We want quick shrinkage, and VEGF inhibitors are really known to kick in pretty quick. So we might say, yes, and a hybrid might be best for you. It also comes down to side effects. Some patients have other medical conditions that preclude us using certain of the combos, and we may even have to go back to the single agent or stick with the single agent targeted therapy in some patients. There's also the issue of which side effects they get. VEGF inhibitors, many people in the audience are on them right now, have some chronic low-grade toxicity, and you stay on this drug indefinitely until it stops working. And that can have some effect on quality of life. Immunotherapy, some people have no side effects from it. Other people have quite significant, and we just have to talk the pros and cons of the side effect profiles and what's if it's contraindicated or not in person. There's are some long-term side effects too. VEGFs wear off really quick. So for the acute side effects, it's pretty good. If you need to stop it, you can stop it, and wears off within days, usually the side effects. But immunotherapy is kind of like a train, and you're on that train and it takes a while to stop it. And then long-term wise, there can be some long-term damage done by both types of drugs. And so we have to look at, again, the patient and talk to them about which are the ones that concern them the most. And patient preference. I mean, we have to take into account logistics too. Not everybody lives right next to a cancer clinic, and some involve more visits than others to the cancer clinics. A lot of treatments done virtually now, and some are more amenable to that. And cost, some people may want, we're going to show some of the examples of the options that are available now, and some of the options that are proven but not available and may need to use some insurance and other things. So that's kind of a few of the things. I'm not sure if the others want to chime in with a few other things they talk about with patients when they start up.
Well, that's fantastic. Jeff, any comments?
No, I think Neil did an excellent job summarizing that. It really is the golden question, in terms of what combination to use, and there's some nuances to deciding, but it's nice to have all these options, I think so.
And to our patients out there, it is a long conversation. It's probably for those of us that treat genitourinary cancer right now, it is the longest and most complex discussion that we have with patients, this decision. And we hope we take the time you need for it. Sometimes I'll see patients and it's just so much information, especially if they're hearing news about where their metastases are for the first time, or even that they have metastatic disease. And so sometimes what we'll often do, even though it requires an extra trip, is say, absorb this amount of information, come back in 2 or 3 days and let's go over options again. Most of us will give written information to our patients from all different sources. And what I'll often say is, don't even look at anything else today. Just put it on the shelf tonight when you go home, start fresh tomorrow. So you're overwhelmed, we're overwhelmed, and that's okay. We have time to kind of work through it in most cases. So if you need the extra time, make sure you ask for it. Go ahead, Jeff. Yeah,
well said, Lori. So the next question I suppose is a combination always necessary? And I would say perhaps this is an area of debate in some ways. So I think specifically there is a question around the favorable risk patient group. So these are patients who don't have any of those HANG or IMBC risk factors. And thankfully, this group of patients actually does quite well. The prognosis is quite long, even with VEGF targeted therapy alone. But these patients were particularly included in the trials that looked at combinations, particularly the VEGF immunotherapy combination trials were powered or designed to look at the entire group of patients, and then presented subgroup analyses. In the favorable risk group, because follow-up time isn't long enough, there hasn't been definitive survival advantage with the combination. It looks like the progression-free survival, so patients tend to have a delay in progression with the combination, but we're still waiting to see if that actually translates into improvement in overall survival. So I think that's something to consider in this favorable risk population. I think another, some nuances is also, is the patient a candidate for immunotherapy? So are there contraindications to immune checkpoint inhibitor therapy, such as, really severe autoimmune disease? Are there questions that often come up? Is the patient able to come in for IV infusions? Do they live in a remote setting? Do they prefer just an oral therapy? So they're all discussions that can be had in the clinic. I think for intermediate poor risk patients, though, I think the wide consensus amongst researchers and clinicians who treat GU malignancies would say that they should have a combination. Another thing to think about in the favorable risk group is do they require treatment? And I think active surveillance is something that we often think about. In fact, there was some data out of Canada using our CKIS data that actually Neil helped lead, identifying a group of patients where perhaps we can just keep a really close eye on things and treat them once things actually start to grow. So always a combination. I think it's debatable. I think there's a lot of nuance to that. And it requires really detailed patient discussions, particularly in those good risk patients. I don't know if Neil or Laura have any comments on that.
Neil, anything else?
No, I think that was great. It is true that there's no cookbook for this. That's a discussion that Laurie and Jeff have said that you have with the patient. And I think that there's lots of options to pick from, and it's just trying to put it in context for the individual patient.
Yeah, and we're going to get to side effects in a bit, but I'll also mention sometimes one of the side effects of the immunotherapy is it takes the brake off the immune system, as Neil said, but then the problem is it can have your own body attack your own cells. So that's the major side effects of immunotherapy. So the problem is with people that already have autoimmune disorders, ulcerative colitis, Crohn's disease, lupus, MS. So those diseases can be exacerbated. So there may be a population of people that they're still intermediate or poor risk. You'd love to use immunotherapy, but after a full discussion with you, you just don't we opt to go ahead with a single agent for fear of exacerbating the other disease that may or may not be well controlled. And again, as Jeff definitely pointed out, there are definitely patients who watching them is the right thing to do. Somebody that's completely asymptomatic with a 9mm lung nodule. Well, if they had 9 millimeters, we'd probably hopefully send you for metastectomy. But for example, patients with pancreatic metastases tend to have a very, very indolent course, and it may grow by 1 millimeter every year. And if we can put off therapy for 5 years, then we've hopefully maximized your quality of life. And I'll just bring up one other thing. Sorry, I should have put these in the slides, but some of you on a VEGF inhibitor that started prior to the immunotherapy may be saying, okay, so when are you going to add in the immunotherapy now? So if you've already started a VEGF inhibitor and you're doing well, unfortunately, we can't add in an immunotherapy now. If things go down the road, things start to progress, then we would take you off the VEGF and add in the immunotherapy. But once you start on only a single agent, unfortunately, we're not allowed to add in a second. Mostly because it hasn't been studied. Okay, I do see some questions, but I think some of them are going to get answered in the slides. Okay, Cassie, we'll go to the next slide. Go ahead, Jeff.
Okay, thanks, Laurie. So side effects. Obviously, this is all of our treatments. We need to balance the benefits, effectiveness with side effects and toxicity. So with targeted therapy, VEGF targeted therapy, I think we've become quite good at managing and identifying some of these toxicities. These drugs have been available now for a number of years, as we mentioned earlier. And I think I hope we've developed sort of a good strategy for identifying and managing toxicities. So some of the common side effects, I think you can break it down by sort of the system that is involved. So some common side effects include gastrointestinal, so diarrhea, loose bowel movements, can be troublesome for patients. And there's certainly ways to help manage that with other drugs like Imodium or treatment breaks or dose reduction. So another set of side effects is cutaneous or skin. So patients can develop some soreness of the palms of the hands as well as the soles of the feet. You can develop some skin buildup, which can be painful. Additionally, patients can get some trouble with some sores in the mouth. Other side effects include elevation of blood pressure. So patients who have pre-existing blood pressure issues or pre-existing heart issues need to be mindful of their blood pressure and often check it quite regularly, and may need to modify the blood pressure regime. Other tests I always say are kind of blood work tests that the patient may not notice, but that we pick up on routine investigations. And those would be things like your liver tests. Liver enzymes can be sometimes abnormal and would need to be acted upon. Certain endocrine glands like the thyroid gland can be affected. So we look at those as well, which is a blood test. And then sometimes it can cause some of your other cell counts to be low, like your white blood cell count or platelet count. These are all things that we monitor quite carefully. So, a number of potential side effects. I think they're different than what you'll hear in terms of the immunotherapy side effects. But I think we've come a long way in managing these and hopefully helping to optimize quality of life for patients on these drugs.
Great, thanks, Jeff. Neil, do you want to comment on a few of the side effects from immunotherapy? I might have stole your thunder, I'm sorry.
No, this is a great discussion. I mean, the big thing is both VEGF and immunotherapy, again, much better than the chemo, what we do for other tumor sites with chemotherapy, right? The hair loss and the nausea, vomiting thing. It's both treatments are a vast improvement. And just was going to add something for Jeff that having a little side effect, it's been proven by a Canadian that having a little side effect is a good thing on VEGF therapy, right? That it shows we're at a therapeutic level, but not too much of a side effect. For immunotherapy, it's a different story. Immunotherapy is, what are the common side effects? Well, unfortunately, immunotherapy as a single agent, the occurrence of side effects for any one side effect is quite low. And the total sum is actually only about 1 in 6 people have a significant side effect from immunotherapy as a single agent. That kind of doubles up if you're using dual immunotherapy. But the thing about it is it's an immune reaction anywhere in the body. It can affect any organ in the body. And so it's kind of, the list is endless because, you can have an itis anywhere. The common things, so Jeff might not mentioned the most common one for immunotherapy, the most common one for VEGF is fatigue. Okay, so that's probably the most common side effect people get. But as for the itises, I generally, the top 4 I would list to a patient would probably be, your skin has immune cells in it to keep bugs from going through. So getting a rash is probably not an uncommon thing. Jeff mentioned the bowels. Now the diarrhea you get from a VEGF therapy is more of a angiogenesis colitis, whereas the immunotherapy, it's because we have immune cells in the lining of the gut wall there to keep the digestive bugs on the inside. And if they get too hyperactive from our immunotherapy, you can get some diarrhea from that. Where else? The lung, when we breathe, we have immune cells lining the air pockets in the lung. And if they get too hyperactive there, you might get a cough or shortness of breath. And much like Jeff said, the immune system hangs out in the hormones areas of the body, the pituitary, the thyroid. We have to watch those areas, much like they do on VEGF therapy. So the list is endless where you can have an itis in the body, and we're all learning. There are rare birds that keep popping up. But the main thing is to, much like when you're on VEGF therapy, keeping in touch with your doctor, talking about your side effects, and then we start going down, if it's not obvious, then we start doing the more intensive workup to make sure we're not missing something. And so immunotherapy is the thing about immunotherapy is the way to turn it off is we have to shut down the immune system. And so that's why we need to know sooner than later, because if it's a train that's picking up speed and you wait too long to communicate, then it's really hard to slow it down again. So communication is the key with your team. And but yeah, way better than chemotherapy and different than VEGF therapy, but very, tolerable, and lots of people on it for long periods of time, able to manage their side effects.
Jeff, anything to add?
That was great. I would just add, these immune-related side effects tend to be more common with the combined PD-1, CTLA-4, so the nivo-ipi combination, at least the higher grade immune-related side effects. And then the other thing is that, combining immunotherapy with targeted therapy, we do see this overlap in toxicity, which can be tricky sometimes to sort out if it's the targeted drug versus the immunotherapy drug. So, I think that was a really good overview.
Yeah, great. Thank you both. And one of the questions that Christina's typed in is why should side effects from systemic therapy be reported to the healthcare team instead of the patient trying to manage them on their own? And as Jeff alluded to, this is especially important for combination, but for any of them. So for example, combination, if you're on the immunotherapy and a VEGF inhibitor, as Jeff said, diarrhea, liver function test abnormalities, those can be from either drug and they're managed differently. So if you have diarrhea from your axitinib, we would treat it with Imodium. If you have diarrhea from your immunotherapy, we may need to initiate steroids, as Dr. Ryu mentioned. So it really is important to let us know so that we can make sure you're well, make sure you're not dehydrated, make sure your electrolytes aren't abnormal, make sure you're on the right treatment. And so hopefully when anybody starts an immunotherapy or VEGF targeted therapy or the combination, you're given a lot of information about numbers to call after hours or when you'd have to the emergency room or things like that, because we don't want you to stay at home and get sicker and sicker. And I've never used the train or car analogy. So Neil's made me excited. So I'm going to use the train analogy from now on. I like that one. So Christine, thank you for that question. Next slide, please. So this is a really, really tough one. And it's about sequencing. And we put this specifically in here because Christine had mentioned that a lot of Kidney Cancer Canada members are asking about, if you get this treatment first, what do you get second and things like that. And so it's a busy slide that we're not going to go over, but maybe Neil, I'll just get you to make your comments on something like this slide.
Yeah, just make sure I'm not on mute. Yeah, so yeah, this is, the top, left column is kind of where each person is getting on the train. The top row, you'd go from left to right as you go down the course of your treatment. And that was up until recently everybody, and it changes. The options that are on the are a little different province to province as to what's available at each stop on the way. But as you can see, as you move down the rows, down to immunotherapy, you would, the problem we're having now is governments are very fixated on is their data to support, what you're doing. And when they moved immunotherapy right to the front of the line, a lot of the studies didn't exist, and they're not going to repeat them. So we've had to lobby very hard, like Dr. Kapoor was talking before, to say it's reasonable to do these things afterwards, and they have listened, which is great. But then, you wouldn't repeat immunotherapy as you go down if you've used it as double immunotherapy or single immunotherapy in the first line. And as you can see, we're starting to move things from the right towards the left as time goes by. So then that starts affecting your options down the line. I saw that was a question before. What was if someone got a treatment in their, in the previous talk as an adjuvant therapy, would you repeat it in the metastatic setting? And, that'd be a great question to have to answer in a year or two. That means immunotherapy or adjuvant therapy has come online, but it does affect you in the metastatic setting, what you've used before as to what you would use next. So yeah, you can see, all the different options, and then what you would be as your next subsequent treatment when that first option starts to wear off as you move right across the table.
So I think we'll leave it there for now on that topic, but happy to ask more questions. And I do recognize there's more questions being asked in the chat, but they are going to come up in a few slides. So that's why I'm not addressing them immediately. So we'll put this on pause until we have specific questions later on, maybe. So next slide, please. So kind of what's new and what's coming up. And I would just say lots and lots. And again, as we've talked about, that research train is accelerating as well. And so just a very quick refresher on what clinical trials are. And how we learn about information is we have to study it carefully, because we don't ever want to assume something works when it doesn't. So first of all, drugs are looked at in test tubes and petri dishes and things like that to figure out what activity they have. And then they might enter a phase 1 study. which is a study for anybody with any type of cancer usually, and is looking at what is the dose to give patients, human patients, and is it safe? And a phase 2 study is when you've got your dose that is safe, you move it into studying people all with the same cancer. So this would be a phase 2 study with a brand new drug X in only people with kidney cancer. And historically in kidney cancer for this type of study, it was, does it shrink cancer? Can we actually see it shrink, and by how much does it shrink? If it looks promising, then it moves into a phase 3 study, which is where you take your old treatment and compare it to your new treatment and see which one's better. And usually that is overall survival. Do we make people live longer? But as Jeff mentioned earlier, sometimes it's endpoints like progression-free survival. Can we keep the cancer from growing for longer? Hopefully we look at quality of life. If we do that, do we at least make people feel better as well? And then a phase 4 study is once a drug's approved or a combination, it's just to try to gain some extra information on some side effects and things like that. And one of our dilemmas now is in terms of not all currently funded in Canada, but right now there are 4 different combination treatments that look better than our old treatment of VEGF alone. And we don't know if any one of those 4 is better than the other. So in terms of phase 3 trials, they're actually really hard to design right now because we actually don't know what the best comparator arm is, because we've actually got an option of 4 right now. And again, without going into specifics, 2 of those 4 right now are funded in Canada. So that's kind of where we start with. That's kind of clinical trials, and that's how a drug moves through. And then obviously if it looks promising, then they apply to Health Canada to get funding, or sorry, to get approval for the combination. And then in Canada, there's a whole other process of can we get it funded in Canada? So as you can see, it's a long process. So maybe with that science background for all of you now, we'll move to the next slide, which is a busy one. And again, going on to lots of new information. So maybe we'll start with you, Neil.
Yeah, so yes, yeah, I want to make sure we have time for questions, so I won't go into great detail, but essentially, as I mentioned, things get moved from, the last thing to try to the second last thing to right to the front. Well, right now, this triplet therapy, it's throw the kitchen sink at the patient, use your best drugs all up front. And we participated in this study, the Ipi, Nivo, cabozantinib triplet compared to the Ipi, Nivo by itself. Randomized double-blind controlled study. We're waiting on the results of that, but that's very exciting to see that we're going to maybe consider giving. Now there's a cost to that with toxicity, but it seemed manageable in many patients, and so we're excited to wait on the results of that.
Thanks, Neil. Yeah, we also had that trial open, Cosmic 313. So yeah, I think everyone's really eager to see the results of the triple first-line therapy. HIF2 alpha inhibitors. So I think this is one of the most exciting kind of new drugs sort of in the game right now. I think belzutifan is the name of it. It has been given the name belzutifan. And what this drug does is it blocks HIF2 alpha, which is a target that is involved in the angiogenesis pathway. And right now in Canada, there's a trial looking at this drug versus an older drug called everolimus in heavily pre-treated patients. We don't have it open in Manitoba, unfortunately. I don't know if it's open in Halifax or Ottawa, actually. I know it's open in Alberta, I think. But it's a trial looking at this drug. So I think we're quite hopeful that it will show a benefit. It was actually recently shown to be quite helpful in patients who have a germline mutation in something called VHL, which is a gene involved in kidney cancer. It can be mutated sporadically. You can also inherit a mutation. And I think it was just published in the New England Journal of Medicine that this drug actually seemed to help patients who have an inherited VHL syndrome. So I think it's quite exciting. I imagine this will be looked at in combination with immunotherapy drugs in the future. So I think something to monitor. I think there's a question in the chat here if this was available in Canada. I don't think it's actually available outside of a clinical trial in Canada, to my knowledge. So.
Yeah, I mean, I did get FDA approval quite quickly. It was so groundbreaking. The FDA said, go ahead and launch it. And you don't see that very often for but it's a rare, it's for VHL patients, like for the indication, the FDA, we may be able to talk to companies. So if you're in that small subgroup, there's, but not for sale in Canada yet, not Health Canada approved. So just going, I guess you gave me the next bullet because it's the old guy, right? Talking about the old tie coming back again. This is the interleukin-2. So the trade name Adisleukin is the old interleukin. Very toxic when we gave it. It requires inpatient management, high risk of going to ICU. Essentially in Ontario, there's one place that gave it, one place in Quebec. We sent patients to the US for it. But it's still effective. It has the highest response rates. And I see that recently there's been a publication about proper patient selection. It's getting even higher response rates, which would compete with the current IOs. And I have patients who went through that. And there's probably patients on the line who maybe have gone through it, have a long response to it. But there's this new version, the pegylated version, pegadesilucan. I'm sure if I pronounced that right. And I know Lori is involved with this adding it with immunotherapy. It's attached to a glycol. Pegylation is used already in cancer and other tumor sites, with our white cell boosters and stuff in those settings. So they've done it to interleukin, so it can be done as a one-shot deal, as an infusion. Once every 3 weeks, and probably much better tolerated, and being mixed as a stimulant to help the new immunotherapies. So very exciting times, but not on the market or anything. But actually, I do believe it's on the market in the US for melanoma since 2019, but for renal cell, still in the experimental stage, but very exciting, very, bringing back in a new formulation an old drug.
Nice. That's a very complicated name. Wow. There's a number of other drugs that are being investigated that help essentially enhance the endogenous immune system. So trying to enhance the immune system to attack the cancer cells. Without going into too much detail, there's certainly drugs looking at sort of other checkpoints. There's newer drugs targeting, other checkpoints that we use already, like the PD-1, PD-L1 pathway. Most of these are antibodies against certain immune targets. The last point here is a probiotic, and there was an interesting study that came out, I think it was at ASCO, looking at adding a probiotic to ipi/nivo in patients with metastatic kidney cancer to see if it would enhance the effect of immunotherapy by modifying the microbiome of the gut. And it was I think it was a very early phase trial, like Lori mentioned, that perhaps showed some promising benefit, but certainly needs to be confirmed in a larger trial. But a kind of a neat way to maybe enhance immunotherapy drugs.
Yeah, that's a growing topic. The microbiome affects all our health, and there's quite good evidence out there. Yet taking antibiotics within 30 days of immune therapy really affects the effectiveness of the immune therapy because we knock out the gut's microbiome. So that simple intervention might be the answer to keep everybody getting high response rates. I see Lori gave me another tongue twister for another drug, and again, this comes back to what citravanib, what Jeff was getting at earlier about, our early VEGF inhibitors are very targeted at VEGF. And then as we've branched out, we're getting what we call more dirty targeted therapies that cover many targets. And this one in particular is a drug that apparently targets pathways that influence the immune system as well as VEGF. And so that it, again, be one that mixed with immune therapy to make immune therapy. It allows the immune system to do the job it's supposed to do. So yet another immune facilitator. So this be a very exciting drug to keep an eye on.
Nice. And lastly, although we mentioned earlier that traditionally chemotherapy, cytotoxic chemotherapy drugs just haven't demonstrated much benefit in kidney cancer. But there's still, I think, some interest in looking at novel chemotherapeutics. this being one of them as a possible newer treatment class. I think it'd be very interesting if there's actually a kind of a cytotoxic chemotherapy drug which had activity in kidney cancer, because that would be a big paradigm shift, I think, in the space. But I think this drug here, very early data, so certainly not ready to be used outside of any clinical trial setting.
Great. And again, this is not a complete list. There are other drugs, but again, we just wanted to show all of you that people are working on it. And there are new exciting combinations and drugs. And one of the questions was in the chat was, if you had $1 million, where would you put it to kidney cancer research? And, you know, the very sad thing is $1 million actually wouldn't go very far in some of the clinical trials. These are multi-million-dollar trials and things. So in the interest of time, we're going to hold that, but we do want people to know there are millions of dollars being put into kidney cancer research, partly through Kidney Cancer Canada. So we thank them for that. And we'll move on to the next slide. And so, and I noticed Dr. Kapoor kind of ended with this as well. You know, there are things you can do. One is be your best self, you know, exercise regularly, diet, rest. Mentally, some people find meditation, mindfulness, staying active, social interactions. I think the pandemic has showed us that social interaction is so key to a good quality of life. And stay educated, things like this, and the resources, obviously, kidneycancercanada.ca website. And I do know one of the questions was specifically what special diet to help promote repair to counter negative side effects of treatments. And I wish we knew, you know, we don't know if there's one magic, well, there isn't a magic diet other than, you know, just a heart healthy diet, a low fat diet, lots of fruits and vegetables. Obviously, we can't tell you lots of fruits and vegetables and fiber if we've also given you gluten and causing you diarrhea, because then you'll be maybe a bit mad at us. But and exactly what Neil was saying, you know, maybe in 5 years, maybe we're going to know so much more about this gut microbiome, and we're going to say, you know what, this is what you should be taking, or it should be this little capsule with these bacteria that you should be taking. It's really quite exciting what that may hold. Next slide, please. And so I think we have 4 minutes left. I'd hoped a little bit longer for questions, but at the same time, I do think we've addressed almost all of them as we've gone along. And so one of the last questions is, you mentioned trials open in only specific provinces. Can patients travel to another province to enroll? Neil, do you want to take that one?
Yeah, I mean, as a division head, we get this question fairly frequently out of province, patients asking to come to Ottawa. And I think in Canada, despite the big geography, we like to help out each other. And I think that we do if someone is looking for a trial. My only caveat to that, as I warn patients, it's hard to be on a trial when you're not at home. So it really depends on your wellness and your supports and cost, right? Our OHIP is our basic healthcare is transportable, but your personal expenses on the travel might not be covered, and staying where you're going to stay, and if you're getting sick. But no, I think that have your oncologist, if there's a trial you're interested, speak to the other oncologist, and there's nothing preventing someone from traveling. It's just the logistics and your supports and your health really play into that. So it's not very common, but we have to. I mean, Toronto probably gets the most of it, but we do have people occasionally, like for us, patients from Quebec and coming across for a trial that's not available where they live in Quebec. If we check with Montreal first, and Montreal isn't available, we're more than happy to see them.
Yeah, and I think Manitoba, probably Winnipeg, accrues a lot of patients from outside of Winnipeg, obviously. Yeah, and the same.
Yeah, we do.
And I think you do too, Lori. I know that you get lots of patients from other areas on the East Coast there that just don't have the accessibility.
Yeah,
and we're grateful for that.
Yeah, it works a lot better if patients can drive. Obviously flying is such an expense. So again, patients from PEI or things like that. And maybe I'll just I'm sorry if I'm cutting you off, Christine or you, Mona, but I think this question from Sandy is really a good one. And Jeff, maybe I'll just have you address it because it's so exciting. But basically the question is, where are we in terms of the molecular oncology? Where are we at in kidney cancer? And again, maybe person might know a little bit more about breast cancer, for example, where we're a lot further along. But Jeff, maybe I'll just let you answer that if you don't mind.
Sure. Yeah. Thank you. Yeah. So I think it's interesting. I think renal cell carcinoma, we've really dissected the molecular biology of the tumor quite well over the last decade, and that's led to the development of these targeted drugs. More recently, the discovery of a drug which can block the HIF-2 alpha molecule. I think despite our understanding of the pathogenesis, I think one thing that we haven't really been able to identify is biomarkers. Maybe that's what you're alluding to, Lori, such as like HER2 or ER/PR status in breast cancer. There isn't a good equivalent in kidney cancer to sort of help guide what treatment to use in specific patients. I think there's a lot of interest in looking at genomics and transcription pathways and trying to see if there's subsets based on gene expression that might respond really well to a VEGF alone versus a combination versus an immunotherapy combination. So there's a lot of work on that in that space, trying to find not just good biomarkers, but biomarkers that you can use in clinic and that you don't need to rely on like a genomics expert to provide. So yeah, I hope that answers your question. I think there's lots of interesting work in molecular oncology and kidney cancer. And hopefully, the next 5 years we'll see some biomarkers. I think would be nice. I think most people would agree that would be a helpful way to help decide what treatments work best in specific patients.
That is the hope, isn't it? I do have one quick question, because this is a question that comes up from our patients over and over again at Kidney Cancer Canada, and we're never really sure how to answer them. And you have touched on this throughout your talk, but we have many patients who are stage 4 and thriving, doing really well. And that's, in part because of these wonderful new treatments that we're offering them. But they do carry a lot of anxiety about what's next for them. They are very concerned about what is line 3, 4, 5, 6. I know there isn't a lot of data, but maybe coming from the experts, you might be able to better explain it to them. What's next? How can we help them?
Thanks, Christine. Do you want to take that one, Neil?
Ooh, it's always a chess game, right? When we're dealing with patients for any tumor type, as to what, always want to think what your next option is. And that's why, we talked a little bit earlier about never giving up on an option you're on, unless we're absolutely sure that it's true progression, that really this drug's not the drug for you. So it depends how you're, the drug's wearing off. If it's oligometastatic disease, like one spot growing, we'll talk to our radiation colleague. Someone had mentioned a question there, where does radiation fit? People always talked in the past, radiation is, kidney cancer is radiation resistant. It is not. Radiation works very well in kidney cancer. So we talk to our colleagues. So even if we have another drug lined up, 2, 3, 4, and we haven't touched those yet, we would never give up on the first drug till we're absolutely sure. Make sure people are on the maximum drug tolerable, because a lot of people get dose reductions and then never escalate again at time of progression. They just move on to the next. It's again, we work as teams, both locally in our cancer centers, as well as across Canada. We share our insights with the new virtual world. We're able to share, insights across the country. And sometimes people are, when they get we ask advice from our colleagues. So always, before you give up on any treatment, just say, is there anything we can do to keep me on this treatment? If we do move on and you're getting near the end, clinical trial, even if you have a standard treatment coming up, if you're offered a clinical trial, I would say go for a clinical trial. Even though we say these things work great, and they do work great, there's lots of room for improvement. And anybody who's fit enough to get on a clinical trial, I'd strongly encourage you to do so. Gives you an additional option. And many of our governments are now appreciating that should not obviate future options if you've gone on a clinical trial, that you volunteered your time to get, help us clinically and maybe get you a new option, but gives you another line of options. So I'd strongly encourage going for clinical trial. But those would probably be my 2 top tips for maximizing your options. We're also innovative when we start getting down. There are some old school stuff we do too that we haven't talked about. So
And I just, again, for the audience, rest assured, and as Neil said, we're a great Canadian network of kidney cancer treaters. And so we are advocating all the time, provincially, locally, nationally on your behalf. And we want you to have as many options as possible as well. And so we're with you on that, I promise you. And we will always do individually and as a group, we'll always do as much as we can to get as many options for you. Rest assured.
I will attest to that, Lori. Thank you. In my years with Kidney Cancer Canada, I realized what a tight-knit group we have here in Canada and how fortunate we are for our specialists, not only surgically and oncology. You know, like if somebody doesn't have the answer, then we pull together, and I am amazed at our specialists. I'm so grateful that we have you all in Canada. So thank you. And thank you for speaking today. I think that kind of ties up our questions, and we're going to move on to another patient story. But I am so grateful for you all joining me, and this has been a very informative session. I'll be glad to have it on the website so that we can refer our patients to this conversation. So thanks and take care.
Thank you. And thank you all for, again, inviting us, and thank you for allowing us to be your physicians. It's our pleasure.
Thanks, Lori. Thanks, Neil. Thanks, Jeff.
Thank you so much.
Take care.
You too.